Thank you for the introduction.
Did you want this?
I think it'll be okay. Everyone can hear me? Okay. Sure, I can use the microphone. Yeah. Yeah, no worries. So first I just wanted to play a video that Verity had recorded for you all, so I'll just try to get that set up first. Unfortunately, she wasn't able to make it today, but she did want to share some things with you. So hopefully this will work. I think I just need to plug this one in. All right, let's try.
Can we turn down the back lights, please? Thank you.
I don't think that's working. Let's see. Okay, can you plug it in, please?
Hi, everybody.
Sorry for the delay, everyone. Thank you for your patience.
Is there one over there?
Nope. That's okay. Maybe I'll just present my stuff first, and then we can do Verity's video once Jeremy helps us get this set up. All right. So I just wanted to talk today about a little bit of the research that I was doing over the last year, in the last year of my degree, and with Dr. Verity Pacey and Penny Ireland. Excellent. So as a background, skeletal dysplasia is an umbrella term used to encompass over 450 different congenital disorders, primarily affecting the growth and development of bone and cartilage, including OI. They are associated with many different impairments and often including marked short stature. And they can be further classified as proportionate or disproportionate based on the presentation of limbs to trunk length ratio, where often disproportionate conditions have shorter limbs relative to their trunk. There are also a number of different secondary impairments associated with these conditions across many different body areas, such as those listed on the slide here, and I think Prof spoke nicely to a lot of those this morning as well. And in conjunction with those impairments and altered biomechanics, this can often result in different activity limitations and participation restrictions in everyday activities. So looking into what research has been done already, it has really focused a lot on children and a lot on different types of disproportionate skeletal dysplasias, such as achondroplasia. And what they have found is that this population group often experience greater limitations in physical functioning, especially across different areas such as mobility, reaching, self-care, and household tasks. And they also rely on more increased use of assistive devices, environmental modifications, and help from others to help to complete these tasks. But what we don't know in the research is what degree of assistance is required. What level do they need to perform these everyday tasks? So the Functional Independence Measure, or THIM for short, is an 18-item standardized measurement tool used to quantify levels of assistance or levels of independence in different areas across everyday activities through mobility, self-care, and cognition. And each item is ranked on a scale of 1 to 7, where 6 to 7 mean that they are independent with the task, 5 means they may need help with setting up the task, or they may require supervision, and 1 to 4 would be varying levels of hands-on assistance from another person. So this measurement tool is something that I use in my research, and it has shown to be feasible in other skeletal dysplasia studies as well. It can be done face-to-face or remotely, such as through Zoom or on the phone. Excellent. So the aim of my study was to quantify the range of functional performance in Australian adults with skeletal dysplasia across self-care, mobility, and cognition. So how we did this is we first conducted an online survey where demographic information was collected, as well as information on functional performance in everyday activities. We then contacted those participants to complete the FIM assessment through the phone or Zoom. And after that, they had received a report which outlined their functional challenges taken from their survey data as well as through the FIM. So that's an example of what the report looked like. It just goes through what they're independent with and what they struggled with in their everyday lives. And it was a very useful tool to help support NDIS applications, as well as providing to different members of the healthcare team to just give a better overview of what areas they may be struggling with and might need more support in. So the results of my study, we had to interpret the data quite early on just due to assessment and university assignments. So we only had 16 participants at the time. This was back in May this year. And we were able to capture 10 different types of clinical diagnoses, which was great. 2 of the participants had OI, and there were reported comorbidities as well as those listed on the slide there. What we did find was that no participant had scored completely independent across all those 18 items. And more difficulties were observed within self-care and mobility compared to cognition, which is what we had hypothesized. But within self-care, we saw the most variability in scores. However, most people were independent to some degree. They just had relied on other forms of equipment or modifications or increased time compared to their peers to complete the task. So this slide shows the distribution of FIM scores across self-care areas. So on the left-hand column, we have the different areas of self-care, from eating down to bowel management. And then through the slide, it just uses a traffic light pattern. So the dark green represents full independence, whereas the light green would show modified independence. So like I said, using equipment or extra time or modifications to perform the task. Whereas the yellow is supervision, and the oranges to red are the hands-on assistance from another person. So as you can see, most people were independent or modified independence within self-care. And with the bladder and bowel management, those were relating to frequencies of incontinence or accidents, or use of medications or pads. Within mobility, we were looking at transfers from different types of furnitures, as well as walking and use of stairs. As you can see, no one was completely independent with using stairs. Everyone had reported at least using a rail for that task. And then lastly was within cognition. So scores were quite high in this area. One thing that we did hear quite often was feelings of social anxiety or avoiding social interactions due to their skeletal dysplasia. So I just drew out some data just more specific to OI. Since that data was analyzed in May, we were able to recruit one more participant with OI. So this would be taken from 3 participants total. And it just shows just the variability amongst individuals with OI and different forms. So what are the key findings from this research? I think it really shows that the majority of adults with skeletal dysplasia do experience challenges with functional independence across everyday activities. However, there's a lot of variability, and a lot of people can achieve independence with different types of supports from equipment or modifications in their home environments. And I think the lower independence scores are likely a result of the clinical presentation. So people use different strategies to access furnitures, altered gait patterns, such as shorter step lengths, took people longer to get places, or with OI, like being more hesitant with where you're going and the environment to reduce risk of injury. A lot of other symptoms such as pain, fatigue, and stiffness also contributed to lower scores as well, as people needed to take rests or breaks to complete the task. But I think these research findings are very important for clinicians so that we can raise more awareness of some of the functional challenges that are faced by individuals with skeletal dysplasias, and that we can better target interventions and provide the necessary supports needed for this population group. So this survey is still ongoing at the moment. We are currently recruiting still. There's a QR code here if you'd like to participate. We also have some flyers just at the back table there, or come find myself or Jeremy at any time today, and we're happy to set that up for you. takes about 20 minutes for the survey and about 15 minutes for the FIM assessment. But I think it's a very valuable tool, and hopefully we can get it published once we have enough numbers and just get a broader understanding of different types of skeletal dysplasias. So maybe more participants without eyes. So we can just really look at that variability and raise more awareness among other colleagues in the medical, rehab, disability fields of this rare condition. Thank you for your time today. Hopefully I will try to get this video set up now from Verity. Let's give it another go.
Hey everybody, I'm so sorry that I'm not there with you today. I really did want to attend, but unfortunately.
I think I just need to change this one. Do you know which one?
Try.
Headphones?
Yeah.
Fingers crossed.
Hi everybody, I'm so sorry that I'm not there with you today. I really did want to attend, but unfortunately I'm heading to Melbourne for a physiotherapy conference. I'm very thankful that some of the team that I work with are there with you, and they're very happy to chat with you about any of the things I discussed today, or for you to get in contact with me afterwards. They can pass on my email address. I'd love to be in contact. So I'm just going to give you a little bit of an update in terms of what's been happening in our research and allied health space here in Australia over the last couple of years. It's been a while because of COVID. So starting off, I'm just going to talk a little bit about the Pain in the OI project, which I've been lucky enough to be invited to be a part of. So it's been organised by OIFI and the Osteogenesis Imperfecta Foundation from the US. And Western High, the president of OIFI, is running it. It's an international group and we're meeting about every 2 months. I get to most of the meetings, not all of them, because the next one coming up is at 3 a.m. Being in Australia, our time for international meetings is always challenging, as I'm sure many of you know. This group was put together to really focus on pain in OI, because that was a priority for OIFI and the OI Foundation. So we've been given the focus of assessment of pain recommendations for people with OI, developing educational resources and running activities around pain in OI, and coming up with chronic pain management recommendations for people with OI. The sub-projects which are really running and happening at the moment are a toolbox of pain resources for adults, and that is really starting to take shape and looking fantastic, and hopefully as that starts coming through, that'll be shared across all of the OI societies, and I will certainly make sure that our OI society in Australia is aware of the resources and can link through to all of those. The other thing which the sub-project running is on minimum requirements for clinical trials. So making sure that pain measurement when there are drug trials being run, or if there are conservative interventions, things like exercise, we're not just asking about how bad's your pain from 0 to 10, but we're really starting to think about what are the key aspects of pain, thinking about chronic pain, as well as acute pain, say from fractures, pain changes that happen as a result of the timing of medications such as bisphosphonates, and really starting to put that together and make some clear recommendations so we can get good measurements of the impact of some of the different medications and interventions which are being done on not just pain intensity for somebody, but the impact of pain overall. So that one's really exciting, and certainly I'll keep you updated as more is happening in that space. Next up, I want to say a really big thank you. Last time I presented a conference which was at the airport hotel again in Sydney, a number of you took part in some research. We then travelled quite around Australia, Marie and I, who was with me at the time, and we saw a number of you in different places as well. And that led to some work being finalised now, which is fantastic because COVID has slowed everything down for us. But we've titled this the development of the screening tool for everyday mobility and symptoms, or the STEMS, for people with skeletal dysplasias. Now this article is available online for free. Anyone can find it. If you pop those details in, it's very easy to come up with, and I can send through a link for anyone who is interested as well. Basically, if you did that study, you remember doing things like a 6-minute walk test, and we asked you a whole bunch of questions as well. And what we have pulled together is really thinking about the mobility of people with skeletal dysplasias across 3 different environments. Because often when we're talking about these things with patients, we talk about, how are you going? We watch you walk up and down the hallway, but we don't get to really get stuck into the details of how you're mobilising, moving, and the symptoms associated with that in all the different environments that we need to go into every day. So we've focused on home, then work or school, depending on what you're up to, and the community. And for each of those different environments, we've asked you about the walking device that you use, from no device at all through to a wheelchair or powered mobility, but also the symptoms that you have at the end of the day. So sometimes you get a bit of pain when you get up and you get moving. Other times you may not have it at the time, but by the end of the day you can be very worn out. We can be really achy and sore as a result of it, and we're often not capturing that in clinical appointments when we're seeing patients and when we're chatting with individuals who have OI. So we're really trying to take hold of that so we can better understand your experience and then hopefully help you further as health professionals in trying to manage your symptoms. So we were also asking you about symptoms, so whether you have none at all at the end of the day, whether you only have pain, whether you only have fatigue, or whether you have both pain and fatigue. And so when we did this study, as I said, we went all around the country. So from North Queensland down into Melbourne along the east coast. We never hit Tassie or Northern Territory. Every other state we covered. We also went to Adelaide and Perth as well to collect data. We had 42 people with OI who took part in this study out of a total of 150. So the 150 people covered all different types of skeletal dysplasias and all different ages. What we found is if you look at the graphs here, you can see that I've got the 3 different environments: home, schoolwork and community. And this is focusing on the symptoms that you're experiencing in these different environments. Up on the side axis, it's the percentage of people. So that's the percentage of the 150, everyone all together, who had the different symptoms in the different environments. So that dark kind of maroon is no symptoms. That's a good colour that we want for this. And you can see that in the home environment, about 50% of people didn't have any symptoms, which is wonderful. But when we then move down to the community, it's a much lower proportion. So it's not even 30% of people who don't have symptoms when they're out at the end of the day, if they've been out mobilising in the community. You can also see that bright red colour, which is both pain and fatigue. That's the C, it means both pain and fatigue. And you can see that there's a small proportion of that in the home environment, getting larger down to almost 50% in the community environment as well. So as we're actually looking not just at how are you walking, do you get any pain, do you get tired at the end of the day, but we're thinking about which environment you're in and where you're spending your time, you can see that an increasing number of people are reporting 1 or 2 symptoms, and they're also getting a decrease in the number of people reporting no symptoms at all. So clearly there's some things going on here, which is healthcare professionals, hopefully we can do more to support people with skeletal dysplasia conditions, including OI, to not just think about what age you're using in different environments, but how we can try and reduce the symptoms and the impact of that as you're mobilising around. So the next steps for us, first of all, this work has been and is the process of being presented nationally and internationally to both healthcare professionals, so they're more aware of the burden and the impact of symptoms in different environments, and also to patient societies like today. Marie Cousins, who many of you met, I've got a photo coming up if you can't remember her, is focusing on writing a paper just on the individuals with OI, which is really looking at gait self-efficacy, which is confidence walking in different environments, safety concerns within different environments, and the symptoms of mobility that people with OI have. So those same things in terms of the aids and the pain, or fatigue, or pain and fatigue across the different environments, and just the OI group is part of that. So certainly when we've got that finished and it's out there and we've got those results, we're very, very happy to share them with you and let you know about them. We're also trying to make this more useful. The whole idea of developing the STEMs was to try and give patients a tool and a language that they could be taking into healthcare professionals. As I said, as healthcare professionals, we have limited space. We often just look at you walking, ask you a couple of questions and move on. And people or healthcare professionals who maybe aren't physios or OTs, so some of the doctors, they may not be as aware of asking about some of these things. So the idea of us developing this tool was really to try and help patients go in and seek access to the healthcare professionals who can support them and get support for the symptoms which are being experienced. So we've got some physiotherapy students who have been involved in another study, which Jeremy and Daphne will be presenting to you shortly. But they're exploring this a little bit further coming up. So Ben, I've got some pictures here, is actually looking at that tool. So when we did it as part of the study, we asked questions and we documented it down ourselves. But for this to be really useful for lots of people in lots of different healthcare environments, it needs to be something which everyone can access, and it can't just be dependent on the healthcare professional that you see. It might be a GP who only has 1 or 2 patients with OI, if that. Knowing that the STEMs exist and that it can be used to really try and understand what's happening for you across different environments. So Ben has put together the questions online of the STEMs, and we're looking at validating that, so finding out can we get the information the same way just from you answering some online questions versus when we actually have a chat with you about it and talk through it to come up with those responses. If we get some really good results from that, what we want to do is to have the online version of the STEMs freely available for all healthcare professionals and all patients to access. That could be through something like the OI Society. We're also working with the SSPA, the Short Statured People's Association of Australia, and it might be through there or through some of the clinics that you go to, that there'd be a little link so you could actually go in and fill that out and have that information ready to go when you go to see a healthcare professional, to help get you into some referrals to other healthcare professionals, to ensure that people are helping you in the things which are really impacting your daily activities. We also have Cynthia and Celeste, who, based upon what we found, where we had such a high proportion of people who were reporting symptoms at the end of the day, they're now reviewing the literature more thoroughly and pulling together all the current published findings from across the world on the impact of having a skeletal dysplasia on both mobility and self-care, but then really identifying the pain and fatigue on these daily activities. Certainly from looking at the literature to date, pain is starting to come up and is much more of a focus. You know, not surprising with the group that OFI have got started as well. But fatigue hasn't been mentioned much. So if we can really start to summarise what is out there and make it very clear where the gaps are, then hopefully we can look at gathering more data as an international community and really pulling that information together to try and help our patients when you guys come to see us. And for you to know that there's a voice for those concerns and that there's a way that these can start to be addressed, because we can't really develop good interventions until we know that the problems are there to begin with. So that's where that's heading. We've got a few other students doing a few other projects as well, which Jeremy and Daphne may mention. But just a little bit more of an update for me, because I know I've only got a short period of time. So big thank you from Marie. Many of you met Marie at the last conference here in Sydney. Marie's PhD student in Belgium. She's almost complete. She's due to have a bub very soon, which is very exciting. Her study with individuals with OI has been really disrupted by COVID. Even now we're not allowed to do research in people's homes, so we can't come and do physical assessments like we have previously and travelled around the country to do that. People can only come to us at the university. In Belgium, Marie's collected all of her data. Here in Sydney, we've just got all of our data on the physical assessment measures, but we're still going to be in contact with people about measures of physical activity and sleep and diaries, which were a part of that study as well for those of you who did participate. If you didn't and you're keen to have your physical activity and your sleep measured, please have a chat to Daphne and she would be able to grab your details for me being in contact. But for those of you who have been a part, huge thank you. The first papers are starting to come together. And you can see there that Marie, there's some posters that she had at the International OI Conference, which was held in the UK a few months ago that she attended. There's one poster there on some of the preliminary findings, which were just the Belgian participants. But the other poster is actually what she plans to do following her PhD, after she's had her bub, and where she's hoping to get an exercise intervention for adults together. So she's currently doing some safety data, making sure that the types of exercises she's looking at working with individuals with OI with are safe for people to do and that they're actually having an impact, and then she'll look at taking those studies further. Hopefully here in Australia we'll be a part of that as well. Marie and I keep in regular contact, and I'm hoping that we may be able to engage in some of those intervention studies in the future. Now finally, I just want to touch on the Allied Health Guidelines. I mentioned this last time I came, the study was almost ready to roll out, and then it kind of came on board as COVID started. It got really slow. We've had an amazing master's student who is actually one of the clinical physiotherapists at the Children's Hospital at Westmead, who has been working as part of a master's of research on this study. So we've rolled out recruitment through the Children's Hospital at Westmead, but not really gone wider than that so far. So this is a survey which we're sending to families and also to healthcare professionals involved with individuals with OI, any age, anywhere in Australia. It's very Australian. So there's international recommendations, but they're in detail, and it doesn't really take into account the healthcare system that we work in here in Australia with places like NDIS, our public, our private system, those sorts of things as well. So I'm really trying to gather the voice of everybody who has OI, everybody who has a child with OI, a family member with OI, anyone at all. So far we've had 35 people take part, 31 of whom have been parents of children with OI. We've had 28 healthcare professionals take part, and they have actually come from across 6 states and territories here in Australia, which has been fantastic. But we're really hoping to have more people get on board. And again, Daphne has some details of this study. So I know that there's surveys everywhere at the moment. I get them all the time too. But if you're interested in helping us develop these guidelines, again, we want them to be things which will be available freely online to anyone who has OI, to any healthcare professional treating someone with OI. And it's about allied health, so it's about physio, OT, social work, all those sorts of things. Not just the doctors and the medications. We're interested in what can we do to help you with your symptoms, with your daily activities, participating in everything that you do. So the survey is really talking about which healthcare professionals, so allied health, do you think should be involved? In what setting? So in the public setting, the private setting, NDIS, at what point in time, like what are the key points for you as an individual with OI where you really think you need more assistance? And what are the roles of each of those healthcare professionals? The data that we've had so far is really, really interesting. There's a lot of agreement between healthcare professionals and individuals with OI. I think the healthcare professionals probably are saying more people should be involved more often. And it'll be really interesting as we go further along this path to see, is that because individuals with OI haven't been able to access these healthcare professionals and don't know what's out there, or is it that we're getting a mismatch in what we think you guys need? So we really need your voice. So if you're interested in taking part in that survey, please chat to Daphne. Please email me at any point in time. I'd love to be in contact. I'm sorry if I'm slow in responding though. Things are pretty busy at uni at the moment. And again, I hope you have a wonderful conference. Thank you so much for inviting us to be here today. I really appreciate it. Okay, bye.
All right. Can everyone hear me okay? Yes. Perfect. Can I have the lights on, please? And thanks for everyone for your patience and for these technical difficulties. We do apologize. Big thanks to Verity and Daphne and Cheryl for speaking earlier. And now on to my study. All right. Good afternoon, everyone. My name is Jeremy. I'm one of the physiotherapists who recently graduated from the Macquarie University Doctor of Physiotherapy program. So this is my research study, Consistently, Inconsistent, the use and experience of the National Disability Insurance Scheme for Australians with skeletal dysplasia. So as Daphne already mentioned previously, skeletal dysplasia is a group of over 450 rare heritable disorders affecting the growth and development of bone and cartilage. And osteogenesis imperfecta is just one of the 450 rare disorders that are part of skeletal dysplasia. So how did I get here? As part of our degree, we had to do a research to pretty much graduate, and we got the privilege and opportunity to work with Associate Professor Verity Pacey and Dr. Penny Ireland on their ongoing research, which was about the functional independence, the functional performance of Australians with skeletal dysplasia. So being an international student, I really wanted to learn more about the NDIS and about skeletal dysplasia. So we had an opportunity to have a chat with one of the SSPA members about skeletal dysplasia and NDIS. And what I found most interesting was that there is inconsistent NDIS access approval within Australians with skeletal dysplasia. And I see some of you guys nodding your heads, seeing that it's personal experience. So I found this very relevant to me and to everyone here, and I was very curious why this was the case. So I went into the literature to see what's out there, to see what the experiences are and the effectiveness of disability support, and I couldn't find anything. So that's why I wanted to look into this further, to explore the use and experience of NDIS for Australians with skeletal dysplasia. I wanted to look at the factors that influence NDIS access approval, and for those who do get access approval, the usefulness of the supports provided, and also the level of satisfaction with the NDIS. So this is kind of a busy slide. I'll just redirect you quickly. So this is a mixed methods study, which means there is a survey and an interview portion. So the survey, as Daphne mentioned previously, is the ongoing study that we have. And then my part of the study was the interview portion. So the survey looked at the key demographics, NDIS access status, what supports are provided, and also the NDIS satisfaction rating. Next was the functional independence measure and the pediatric version called the WFIM, and Daphne's touched on that previously. And then on to part two. We selected participants who agreed to do the interviews, and they were about 15 to 60 minutes long, and we asked questions about the understanding of the NDIS, how the application process was like, if they were about to, or if they've been on the plan for a while, what was their plan review process like as well, any challenges in accessing their funding, and their most valuable and wanted supports, also their best and worst experience of the NDIS. So how did we analyze the data? Because in literature, when we talk about qualitative studies, the interviews have to be really objective and rigorous and strict to maintain that objectivity so that we're trying to reduce the bias and so that we can ensure the data is representative in a objective lens. And to maintain that objectivity, we had to analyze the interview transcripts individually. So we had 4 team members that looked at the 14 transcripts that we had, and then we would come together and agree on the themes and sub-themes that were pulled out from those questions and answers. And in the end, we were able to reach data saturation, which means that we were able to have data that was representative and objective from our findings. So the first part of the study was the survey and functional assessment. There were 14 participants that were included in this study. As you can see on the graph here, there are 10 adults and 4 children. All the children represented by their parents had NDIS access. However, the 5 adults did not have NDIS access, whereas the other 5 did. Moving on to the survey results, most of them showed that they were satisfied with their NDIS access, and the supports there were, and these are the supports provided from NDIS. Now onto the interview results. So this is just a quick visual representation that will come up again later on, but this is pretty much what sums up the participants' experience within the NDIS. It's a game of snakes and ladders. And again, I will come back to this at the end of this presentation. So we had 3 themes and 10 sub-themes that came out of these interviews. So the first theme is the consistent process-driven barrier, and what these are barriers towards their NDIS use and experience. These are consistently expressed by all the participants throughout our interviews, and these were all about the processes of the NDIS as well. So to help me explain the sub-themes, I'll actually use the quotations from the participants throughout our interviews. The first sub-theme, the first barrier, is that there is poor knowledge and awareness of the NDIS. This participant felt like the NDIS personnel didn't really understand what the process was themselves either. So this isn't limited to NDIS personnel, but also it was reported for GPs, allied health professionals, sometimes even the participants themselves or the parents representing their children. There was a global lack of knowledge and awareness of the NDIS system. The second barrier is poor knowledge and awareness of skeletal dysplasia. People are really unaware of what we need and the challenges that present. They think that short-statured people are just smaller, but they can do X, Y, and Z like everyone else can. Similar to having a lack of knowledge and awareness of NDIS, there is also a lack of knowledge of skeletal dysplasia. Same thing happens to the NDIS personnel, local area coordinators, allied health professionals, GPs, specialists. Sometimes you just interact with someone who doesn't know what OI is, and they'll have to look it up as you're talking to them. And that becomes a barrier and detracts the experience when you're trying to apply for NDIS or when you're even in the NDIS. Third barrier is language. It is down to the words that you use on the applications. If you don't use the correct words, it gets rejected, which is a bit stupid if you ask this participant. So this participant is accessing the NDIS, has been accessing the NDIS for 2 to 5 years, and even then, they felt that language was extremely important to know the specific terminology and the specific jargon that they look for. And if you don't use that, your application gets rejected or your funding gets reduced or cut. So you have to be very careful there, and because of that, it detracts from your experience as well. This became another barrier. The next barrier is the availability and accessibility. For this participant, it's been very frustrating because they had the funding to get home modifications. But to get home modifications, this participant needed an approval from occupational therapy. However, this participant wasn't able to book in a time for an occupational therapist to come to their home and to give approval for home modifications. So there is a lack of accessibility and availability of certain aspects, certain hoops that you have to jump through just to access the funding you deserve. And as you may know, whoever's on the plan, if you don't use up the funding before the end of the plan, it might get cut. And as a consequence of this certain hoops that you have to jump through, it's really quite a barrier for a lot of people when you have the funding that you deserve, but you're not able to use it. The last barrier is the inconsistencies in processes and outcomes. This participant felt that it was unfair because some kids can just breeze through it, be accepted with no issues, and some people can't. They don't understand how the NDIS can pick and choose. This has been reflected across all our participants that there is inconsistencies within the application process, the approval, the amount of funding provided, just everything is inconsistent, but this is consistently reported within our participants' interviews. So those were the barriers represented by the snakes. The next theme is the inconsistent person-driven facilitators. What facilitators are things or people you interact with that can provide you a better experience within the NDIS space. These are facilitators towards the NDIS use and experience. However, it's inconsistent because you may not be able to be lucky enough to encounter someone who understands the NDIS process or have that knowledge have the knowledge and awareness of the NDIS or skeletal dysplasia. These are all driven by the stakeholders being the NDIS personnel, allied health professionals, GP, etc., as I've mentioned. The first facilitator is person-centered approach. For this participant, she said, "My child wasn't just a number. The NDIS personnel was treating my child as an individual person and he genuinely wanted to help." For a lot of these participants, they felt that having a person-centered approach, interacting with someone who actually wanted to help, provided a great experience enough that even if they were trying to understand the knowledge, understand skeletal dysplasia and NDIS, that already provided a better experience. The next facilitator is, no surprise, the knowledge of NDIS. The more knowledgeable your therapist is, the better, especially with the NDIS. Makes your whole experience a lot better than the ones that don't know anything and you end up having to do the work. If you're interacting with a stakeholder that doesn't understand or have the knowledge and awareness of the NDIS, the burden is placed onto the participants, having to advocate for yourself or for your child. And that becomes, and on the flip side of that, when you do interact with someone who does have the knowledge, it provides a greater experience. Knowledge of skeletal dysplasia. You're dealing with something that's just a little bit different to what you're normally dealing with. We don't see the world like my child does through my child's eyes. Again, having knowledge of skeletal dysplasia provides a better experience because they're understanding the little implications that not everyone else does. And these are represented by the ladders. The last theme is the positive and negative impact of the NDIS. First sub-theme is the positive impact of NDIS access approval. For those who are on the plan at the moment, I'm sure this is what you agree with, is that you're able to get the support that you need to be able to be independent and to have a better quality of life. However, there are a lot of negative emotional impacts as well. For this participant, it was very overwhelming because with the worry that if it was rejected, how are they going to continue to get the needs that my child required? And this has been reported throughout all the interviews that there is an emotional burden and responsibility, stress and anxiety that they're always having to advocate for their child or even for themselves. And this burden is placed onto them, and there is a negative emotional impact. And now imagine for the participants who tried to apply for the NDIS and got rejected. That can't feel any better, or probably definitely worse. So this is just the themes of the sub-themes summarized. And now back to our visual representation. It's a game of chance from what we found from these interviews. If you're lucky enough to hit a facilitator and the ladder is what you can climb, great, it's going to bring you up to the next tile. However, not everyone was able to access the same facilitators, the same person who has the knowledge and awareness. So that's why it's inconsistent. However, all the barriers were consistently expressed by all the participants and experienced by all the participants. Although that they think the NDIS is providing the support that they need to be independent, it almost seems like you're set up to fail at every step of the way. It's also there is no end to this journey. So we can see that NDIS access approval is not the end, because the next thing that's coming along is the next plan review and the next plan review and the next plan review. So what did we find? There is a complex interplay between these consistent process-driven barriers and inconsistent person-driven facilitators, which positively and negatively impacts these participants. So this was the first study that looked into the disability support use and experience for Australians with skeletal dysplasia. And I've brought this up a lot already today. There is such an importance of knowledge and awareness with NDIS and skeletal dysplasia. And also there shows the importance of advocates for Australians with skeletal dysplasia. Advocates can be for yourself or even from the parents. Having someone to help you along the journey, having each other here, such as the society here, is going to provide so much better, a much better experience for everyone and yourself. So what's next? We hope to provide more consistent and accessible methods of increasing knowledge and awareness of NDIS and skeletal dysplasia to all stakeholders. This can range from resource packets to webinars to information sheets that can be accessible for GPs, participants, and even other allied health professionals. And perhaps we should think about streamlining or changing the process of accessing the funded supports so that we don't have to jump through so many hoops just to access the funding that we deserve. And maybe it's also time to reevaluate the NDIS access eligibility process. And finally, we hope to present and report these findings to advocacy groups, what we're doing now, to the government and to other healthcare providers. So once again, thank you so much for your time. This is the research study that is ongoing, and what this is the survey that is going to take about 20 minutes, similar to this. This is the same survey that we've used in the first part of this study. And then the functional independence measure, the FIM or the WeFIM for your child, is something that you can take as evidence and is validated. So this is evidence that you can use to advocate for yourself for NDIS applications or for your next plan review. So I really do hope and really encourage for more participants to be a part of this survey. Daphne and I will be here all day, so please find us, and we're more than happy to go through this survey with you. Thank you again so much for your time.